So you are welcome to this presentation, which is a procedure on the respiratory assessment. So basically, most of the things are in the PowerPoint, which I actually presented earlier. So to look for indications, also principles, everything has been discussed in the PowerPoint. For this one, we are just going into the nitty-gritties of the procedure. Okay, so these are the requirements that are needed for the procedure for respiratory assessment. I've got a depth measure here for measuring the diaphragmatic excursion, a pen for recording together with a plain paper, whatever findings I'm going to find. Also, the nurse's watch to take the respiration rate, and the stethoscope will be for auscultation of the regions of the lung regions on the chest. So this is all that is needed. So with me here is my patient, Mr. WPD, whom we are going to do the examination on today. How are you, Mr. P? I'm fine, thank you, sir. How are you? You are fine? Yes, sir. Good. Do you have any complaints? No. Okay, so Mr. B, you have been admitted. Yes. However, usually we do the respiratory examination so that we keep record of as baseline data. So I'm going to examine your chest. Also, I'll examine the nose. What is involved includes I'll just be looking at you at certain points. Other things includes touching you, and also I'll be using the stethoscope so that I see, I hear the areas of your lungs. So, do you have any problems with that? No problem. So, is it okay? I can go ahead? Yes, sir. Thank you very much. Yes. So, Mr. Billy, I would request you to go on the bed so that you lie on the bed and you can remove the top shirt so that we do the examination. All right. So just like any other procedure, you have to start with the inspection, then the palpation, then the percussion, and the auscultation, as we discussed in the PowerPoint presentation. So I'll start by inspecting Mr. WP. So I'll start from the nose, where I'm going to check for the patterns of the nose. In this case, I required the torch, which I couldn't find. But you are required to use the torch so that you see the nostrils for patterns. Also, you can look for the polyps and also for nasal flaring as well. So after checking for the nose, you can go to the mouth. The mouth, you have to check for pursing of the lips. The pursing of the lips entails to say the patient is having difficulties in breathing. There is basically when the patient is using the mouth, there is a problem. The patient cannot acquire a lot of oxygen with the nostrils alone. So they are using the mouth as well. So pursing of the mouth, the lips indicates low oxygen in this patient. So also on the mouth, you're supposed to check for discoloration of the lips, bluish discoloration, that is what is referred to as central cyanosis. So that also indicates to say the patient has reached oxygen in them. From the nose and the mouth, I have to go to the fingers. Again, on the fingers, you have to check for the cyanosis here. The other thing that you are supposed to check is the clapping of the fingers. So to be sure, you can tell the patient to do like this. Mr. P, you can do like this. Yes. Where you are looking at the angle. If the patient has clapped finger, the angle in between the nails is actually bigger. It is actually visible. And clapping of the fingers, you can drop Mr. P. Clapping of the fingers indicates a chronic fibrotic respiratory disease. That means the patient has been lacking enough oxygen for a long period of time. So after inspecting the nose, mouth, and the fingers, I have to go to the chest, where I'm supposed to check for scars, inspect for scars. Scars indicates previous surgery. Also, I'm supposed to inspect for the veins, visible veins. If there are visible veins on the chest, it indicates to say there is a cardiac problem. Also, the other things that you're supposed to check includes the pectum excavatum, which is the depression in the chest of the patient, where there is a bigger depression going inside the chest. And also the pectus carinatum, where there is actually an elevation on the chest of the patient. In pectus carinatum, you're going to find that the transverse diameter will be equal to the anterior posterior diameter. So to just estimate, you can do like this, then try to measure this anterior-posterior diameter and estimate it with the transverse diameter. So in pectum carinatum, you're going to find that this diameter is equal to the anterior-posterior diameter. So that is what you basically inspect on the patient. And the pectus carinatum, also the pectus carinatum and the excavatum, they also indicate cardiac diseases. So they indicate as the congenital cardiac diseases when they are present. So after doing respiratory examination, you find that the patient has the pectus carinatum or excavatum. You have to do the examination of the cardiovascular system as well. So, after inspecting the chest, the last thing of inspection is where you have to get the pulse, the respiration rate. So you have to get the respiration rate, also checking the rhythm as well. So for the patient not to be that anxious, you have to also be taking the pulse there while looking on the chest and also counting the breaths per minute. So I can see Mr. PD is basically breathing properly. Also the rhythm is okay. And the respiration rate, the normal is between 12 breaths per minute to 20 breaths per minute in an adult. So respiration rate is the last part of inspection. Then from inspection, we have to do the palpation. So Mr. Peter, as I told you, what is involved in examination, to say there will be certain times when I will be touching you. So I will be touching you so that I see if there's something wrong on the chest. So you have to palpate for crackles and lumps. So basically, how do you know these are crackles? They are going to feel like grains of rice as you are palpating here. That basically indicates to say air is escaping to enter the tissues. So basically, after palpating the chest, you are also supposed to palpate for the position of the trachea. So I can feel the trachea is in the right position for Mr. P. There are certain times where you're going to find there is deviation of the trachea on the left side. This implies to say the left lung, there is fibrosis in the left lung, or the left lung has actually collapsed. There is atelectasis. Thereby, this lung is taking more space, pushing the left lung that side. So you're going to find the deviation there. However, a simple deviation on the right side is normal. However, when there is a lot of some deviation of the trachea, that means there is a problem with the left lung. So the tracheal position examination ends the palpation part of this examination. Then from here, the next skill of examination is the percussion, where we have to percuss the regions of the chest. And the normal sound during percussion should be resonance sound. When we hear hyperresonance, it indicates consolidation. For example, in conditions like pneumonia, if there is a reduced resonance, the sound is reduced, it indicates a blockage in the airway, where there is accumulation of fluids in the air. So I'm going to percuss and compare the sounds on each lung. You use the lungs as the control for the other lung. So I can hear for Mr. Pili, the sound is the same all over and it is the resonance sound. So from percussing, the next step is the auscultation, where we are going to listen for vesicular sounds. The normal sounds on the regions of the lungs are called vesicular sounds, but on the trachea, it is called the bronchial sound. Then, as the trachea diverts into the bronchi, the sound changes to broncho-vesicular sounds. So we are going to auscultate, starting with the apex of the lungs, which are in those areas above the collarbones. And we are going to use the bell for this. Mr. Pili, when I move the stethoscope, you breathe in and out. So breathe in, out whenever you move the stethoscope. Okay, so I couldn't hear any abnormal sounds on Mr. Pili. However, you can find to say, apart from the normal sounds, which are the vesicular sounds, you are going to hear abnormal sounds like crackles, also the wheezing. The wheezing basically is common in asthmatic patients. So, but for Mr. Pili, I couldn't hear any other sound apart from the vesicular sounds. So this examination entails to say we are done with the anterior chest examination. We are supposed to do the same on the back in the same manner. The inspection, the palpation, percussion, and the auscultation. So I'll ask you, Mr. Pili, so that you move, so that we can examine the back the way we did. Okay, so now we have to do the same as I mentioned on the posterior part of the chest. For the posterior part of the chest, we have to start with inspection as usual, where we are inspecting the spine. So usually there are too many deformities that happens on the spine. We have got the scoliosis, where the spine moves on the lateral side of the body. So it is going to move like this. Also, we have got the kyphosis, where the spine moves outwards of the body of the patient. So these two basically they interfere with lung expansion. When the spine moves the other way, what happens is it is going to limit the amount of space in the thoracic cavity. So I can see Mr. Pili, the spine is in the good condition and curvatures. So from inspection, we have to do the palpation. Under palpation for the posterior part, we have to palpate for the tactile premitus. Basically, these are the vibrations that are produced when someone is talking. So usually when there is an obstruction, there will be hyperproduction, there will be an increase in the vibrations of these, there will be an increase in these vibrations. So, Mr. Pili, when I touch you, you say 99. When I move again, you say 99. Okay.
99. 99. 99.
Okay. So I can feel for the vibration as Mr. Pili is saying 99, which are not, which are just within the normal range. Then from here, I have to also palpate or estimate the chest expansion. Mr. Pili, when I touch you, I'll tell you to breathe in and out. So hold your breath. You can breathe in as much as you can. Okay, breathe out. Breathe in with all the effort. Breathe out. Breathe in. Breathe out. So there is a gap that is being formed here as Mr. P is breathing. This gap entails to say there is enough chest expansion. You are going to find that when the patient is having difficulties in breathing, when you put your fingers like that, there won't be any gap that will be formed. That means the patient effort to breathe or to take in air is so low. So for Mr. Piri, I can see the gap is okay. The other thing is when the fingers are moving in the right direction, that means there is good chest expansion. But there are certain times when the fingers are moving in the wrong direction like this. You have put them like this, then they are moving in the wrong direction. This is called paradoxical movement, where there is, for example, in chest injuries, where there is the frail chest. So you also take note of how the fingers are moving. They are supposed to move in the straight line or direction. Then from here, I'm supposed to basically this part concludes the inspection of Mr. P. So from here, I'm supposed to do now the percussion. The percussion, I have to do things. I have to do two things. Where I'm supposed to hear for the sounds on the regions of the fields of the lungs. Also, where I'm supposed to examine the diaphragmatic excursion. So let me start with the diaphragmatic excursion, where also examining it just entails on the issue of chest expansion. So I'm supposed to percuss for the area where there is, you can lean a bit forward, Mr. P, where I'm going to get the flat sound. That's where the diaphragm is. So as you can hear, that is resonance. When I go a bit, that is some kind of a flat sound somewhere there. So that was the purpose of that marker, where I'm supposed to mark wherever I get the flat sound. And this marker is not supposed to be irritating to the patient. Then I'll tell Mr. Piri to breathe in, breathe out with all the effort. Breathe in, breathe out, and hold your breath. Breathe out, breathe in, breathe out with all your effort. So I can feel for uh, the flat sound here, meaning the diaphragm, when Mr. Piri breathed in, had to move from that to this position. And this, we have to take the measurements. This is the purpose of this step here. And the measurement I've gotten is somewhere around 3.5, which means there is good diaphragmatic excursion. The normal range should be between 3 centimeters to 5 centimeters. And the marker you are using, make sure that the patient is not sensitive to this marker, and it shouldn't be irritating the skin. So basically, that is the first part of the percussion. So after getting the diaphragmatic excursion, we have to now percuss the regions of the lungs. So to allow the scapula of the pectoral not to shield the regions, we have to tell the patient to lean forward, Mr. Pili, so that the scapula moves away from the region of the lung regions. Then we have to again percuss, comparing the two areas as control. The normal sound, as we mentioned, should be resonance. So basically I can get resonance from all the regions of the lungs. Then after doing the percussion, the next step and the last step is the auscultation, where you are supposed to hear for vesicular sounds, as we mentioned earlier. The normal sound should be vesicular sounds. There are abnormal sounds like the wheezing and also the ronchi. Basically, the ronchi is the sound that is produced when air is passing through a partially obstructed airway by the fluids. Wheezing, again, is a partially obstructed airway, but the ronchi, more fluids as the air is passing against the fluids. That's when you get the ronchi. And the other difference is that the wheezing is more like a whistling sound, a musical sound. The ronchi is somehow flat. So you can concentrate and get those sounds, abnormal sounds as well. But the normal sounds should be the vesicular sounds. So you are going to auscultate in the same way we percussed. Breathe in and out, keep on breathing in. Okay, so that is the last part of the examination, the auscultation, and I could hear from Mr. Billy. I only heard the vesicular sounds. I couldn't hear any other sounds like the wheezing and the long cut. But this is not the end of the examination. To finish up the examination, I'm supposed to order for the sputum and X-ray so that they are examined further. As we mentioned of the pectum excavatum, those can also be reviewed under the chest X-ray. Also, there are certain conditions that can be reviewed from the sputum, like the tuberculosis, or that the sputum can be taken for culture sensitivity or for AFB. So after doing those two, that's basically the end of the procedure, and those results are supposed to be kept in the file of the patient for future reference and also as baseline data. Thank you very much.